Question 1. Consider a scenario where a 62-year-old male presents to the emergency department complaining of sudden onset, crushing substernal chest pain radiating to his left arm, accompanied by diaphoresis and shortness of breath. He has a history of hypertension and hyperlipidemia. His vital signs are blood pressure 150/90 mmHg, heart rate 95 bpm, respiratory rate 20 breaths/min, and oxygen saturation 96% on room air. Which of the following initial management strategies is most appropriate for this patient? Option A. Administer aspirin 325 mg orally, obtain a 12-lead electrocardiogram, ECG, immediately, and administer sublingual nitroglycerin if blood pressure permits. Option B. Administer intravenous morphine for pain relief and observe the patient for 30 minutes before obtaining an ECG. Option C. Administer oxygen via nasal cannula and begin intravenous fluids while awaiting laboratory results. Option D. Administer a beta blocker intravenously and obtain a chest X-ray to rule out pulmonary causes of chest pain. The correct answer is A. Administer aspirin 325 mg orally, obtain a 12-lead electrocardiogram, ECG, immediately, and administer sublingual nitroglycerin if blood pressure permits. Explanation. This scenario presents a common yet critical challenge in emergency medicine: the rapid assessment and management of a patient with potential acute coronary syndrome (ACS). The professional challenge lies in the urgency of the situation, the need for swift and accurate diagnosis, and the potential for rapid deterioration. Mismanagement can lead to significant morbidity and mortality, making precise adherence to established protocols and guidelines paramount. The correct approach represents best professional practice by prioritizing immediate interventions that are evidence-based and aligned with current guidelines for ACS management, as established by organizations like the American Heart Association, AHA, and the American College of Cardiology, AC, which are foundational to PA practice in the U.S. This includes prompt administration of aspirin, oxygen if indicated, nitroglycerin for symptom relief, and consideration of morphine for pain. The immediate initiation of an electrocardiogram ECG is crucial for differentiating between ST elevation myocardial infarction, STEMI, and non-ST elevation ACS, guiding subsequent treatment pathways. This systematic, guideline-driven approach ensures patient safety and optimizes outcomes, reflecting the PA's responsibility to provide competent and ethical care within their scope of practice, as defined by state licensing boards and national certifying bodies. An incorrect approach that delays or omits aspirin administration fails to adhere to the fundamental principle of antiplatelet therapy in ACS, a cornerstone of treatment proven to reduce myocardial damage and improve survival. This omission represents a failure to follow established best practices and could be considered a deviation from the standard of care, potentially leading to adverse patient outcomes. Another incorrect approach, such as administering a beta blocker without first assessing for contraindications like bradycardia or hypotension, or without a clear indication, risks exacerbating the patient's condition. This demonstrates a lack of critical assessment and adherence to evidence-based protocols, potentially violating ethical obligations to provide safe and effective care. Furthermore, delaying the ECG until the patient is transferred to the hospital bypasses a critical diagnostic tool that can be performed at the point of care, thereby delaying definitive management and potentially worsening myocardial injury. This delay is a failure to act with appropriate urgency and utilize available resources effectively, which is a core expectation of emergency medical care. The professional decision-making process in such situations should involve a rapid ABC, airway, breathing, circulation assessment, followed by a focused history and physical examination. The immediate priority is to obtain a 12-lead ECG. Concurrently, initiate appropriate pharmacologic interventions based on presenting symptoms and ECG findings, always considering contraindications and potential adverse effects. Continuous reassessment of the patient's status is vital, and communication with supervising physicians or transfer facilities should be initiated early. This systematic, evidence-based, and patient-centered approach ensures that critical interventions are not missed and that the patient receives the most appropriate and timely care. Question 2. The investigation demonstrates a patient presenting with sudden onset dyspnea, chest tightness, and palpitations. Physical examination reveals a new apical holosystolic murmur radiating to the axilla and bilateral crackles on lung auscultation. An electrocardiogram shows ST segment depression in the anterior leads. Considering the anatomy and physiology of the heart, which of the following is the most likely underlying cause of the patient's presentation? Option A, acute mitral regurgitation secondary to papillary muscle dysfunction. Option B, atrial fibrillation with rapid ventricular response. Option C, pericardial effusion causing cardiac tamponade. Option D, ventricular septal defect with left-to-right shunting. The correct answer is A, acute mitral regurgitation secondary to papillary muscle dysfunction. Explanation: the investigation demonstrates a patient presenting with symptoms suggestive of a cardiac issue, requiring the PA to differentiate between various anatomical and physiological mechanisms. The challenge lies in accurately identifying the underlying cause of the patient's presentation to ensure appropriate and timely management, adhering to the standards of care expected of a physician assistant practicing under U.S. federal and state regulations, as governed by the NCCPA for recertification. The correct approach involves a systematic evaluation of the patient's cardiac anatomy and physiology, correlating the presenting signs and symptoms with known pathophysiological processes. This aligns with the PA's scope of practice and the ethical obligation to provide competent patient care, as mandated by the Accreditation Review Commission on Education for the Physician Assistant ARC-PA standards and the Physician Assistant Oath. Understanding the electrical conduction system, myocardial function, and valvular integrity is paramount. An incorrect approach would be to focus solely on one aspect of cardiac function, without considering the interplay of other systems. For instance, attributing symptoms solely to a muscular issue, without investigating potential electrical or valvular contributions, would be a failure to conduct a comprehensive differential diagnosis. This could lead to misdiagnosis and delayed or inappropriate treatment, violating the PA's duty of care, and potentially breaching the standard of practice established by state medical boards and the NCCPA. Another incorrect approach would be to rely on anecdotal evidence or non-evidence-based practices, which contravenes the principles of evidence-based medicine that underpin PA practice and are implicitly expected by regulatory bodies. Professional reasoning in such a scenario requires a structured approach. First, gather a thorough patient history and perform a comprehensive physical examination, focusing on cardiovascular findings. Second, utilize diagnostic tools, e.g., echocardiogram, laboratory tests, to objectively assess cardiac structure and function. Third, synthesize this information to formulate a differential diagnosis, prioritizing the most likely causes based on the patient's presentation and diagnostic findings. Finally, develop and implement a treatment plan that addresses the identified pathology, with ongoing reassessment and adjustment as needed, all within the established legal and ethical framework for PA practice in the United States. Question 3. Upon reviewing the vital signs and physical examination of a 68-year-old male presenting with acute shortness of breath and a pulse oximetry reading of 88% on room air, you note bilateral crackles on lung auscultation and a history of recent upper respiratory infection. Which of the following pathophysiological mechanisms is most likely contributing to his hypoxemia? Option A, reduced respiratory drive. Option B, increased physiological dead space. Option C, decreased diffusion capacity of the alveolar capillary membrane. Option D, ventilation-perfusion mismatch. The correct answer is D, ventilation-perfusion mismatch. Explanation: scenario analysis. This scenario presents a common clinical challenge where a patient's symptoms suggest a specific physiological dysfunction. The challenge lies in accurately identifying the underlying anatomical and physiological cause of the patient's dyspnea and hypoxemia, which is crucial for effective diagnosis and treatment. Misinterpreting the findings could lead to delayed or inappropriate interventions, potentially worsening the patient's condition. The physician assistant's role requires a thorough understanding of respiratory system mechanics and gas exchange principles to differentiate between various causes of respiratory distress. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's presentation, correlating the observed signs and symptoms with known physiological processes of the respiratory system. This includes understanding how impaired gas exchange, altered ventilation-perfusion ratios, or mechanical limitations in airflow can manifest. By considering the patient's history, physical examination findings, such as crackles on auscultation, and diagnostic data, low SpO2, the PA can logically deduce the most probable underlying issue. This aligns with the Physician Assistant National Recertifying Examination's emphasis on applying foundational medical knowledge to clinical problem solving, ensuring patient safety and effective care delivery as mandated by NCCPA guidelines for recertification. Incorrect approaches analysis. One incorrect approach would be to focus solely on a single symptom without considering the broader physiological context. For instance, attributing the dyspnea solely to anxiety without investigating potential organic causes would be a failure to adhere to the principle of comprehensive patient assessment. This overlooks the potential for serious underlying pathology and violates the ethical obligation to provide thorough care. Another incorrect approach would be to immediately initiate aggressive interventions without a clear diagnostic hypothesis. A prompt treatment is important. Acting without a reasoned understanding of the pathophysiology can lead to iatrogenic harm or mask the true diagnosis. This demonstrates a lack of critical thinking and a departure from evidence-based practice, which is a cornerstone of PA practice and recertification requirements. A further incorrect approach would be to dismiss the findings as insignificant or transient without further investigation. This demonstrates a failure to recognize the potential severity of respiratory compromise and a disregard for the patient's subjective experience of distress. Such an approach could lead to a misdiagnosis of a life-threatening condition, violating the PA's duty of care. Professional reasoning. When faced with a patient presenting with dyspnea and hyposemia, the professional decision-making process should involve 1. Gathering a comprehensive history, including onset, duration, exacerbating and alleviating factors, and associated symptoms. 2. Performing a thorough physical examination, focusing on the respiratory system, but also considering cardiovascular and other relevant systems. 3. Reviewing available diagnostic data, such as pulse oximetry, arterial blood gases, and imaging studies. 4. Formulating a differential diagnosis based on the collected information, considering common and serious causes of respiratory distress. 5. Prioritizing investigations and interventions based on the most likely diagnoses and the patient's clinical stability. This systematic approach ensures that diagnostic and therapeutic decisions are evidence-based, patient-centered, and aligned with professional standards of care. Question 4. Process analysis reveals a 65-year-old male presents with sudden onset of right-sided weakness and difficulty speaking. On examination, he exhibits a right hemiparesis, aphasia, and facial droop. His sensation is intact to light touch bilaterally. Which of the following anatomical structures is most likely involved in this patient's presentation? Option A. The brainstem, impacting cranial nerve nuclei and long tracts. Option B. The right cerebral hemisphere, specifically the corticospinal tract and Wernicke's area. Option C. The left cerebral hemisphere, specifically the corticospinal tract and Broca's area. Option D. The cerebellum, affecting motor coordination pathways. Correct answer is C. The left cerebral hemisphere, specifically the corticospinal tract and Broca's area. Explanation. Scenario analysis. This scenario presents a professionally challenging situation because the PA must integrate complex neuroanatomy and physiology knowledge with the practical application of diagnostic reasoning in a time-sensitive clinical setting. The challenge lies in accurately identifying the most likely neurological pathway affected based on a constellation of symptoms and signs, while also considering the differential diagnoses and the implications for patient management. Careful judgment is required to avoid misdiagnosis, which could lead to delayed or inappropriate treatment, impacting patient outcomes and potentially violating standards of care. Correct approach analysis. The correct approach represents best professional practice because it systematically analyzes the patient's neurological deficits, correlating them with specific anatomical structures and physiological functions of the nervous system. This aligns with the Physician Assistant National Recertifying Examination's emphasis on the application of foundational medical knowledge to clinical problem solving. By identifying the lesion's likely location based on the pattern of sensory and motor loss, the PA demonstrates a thorough understanding of neuroanatomy and physiology, which is a core competency for safe and effective patient care as mandated by NCCPA guidelines for recertification. This methodical approach ensures that diagnostic and therapeutic decisions are evidence-based and patient-centered. Incorrect approach is analysis. an approach that focuses solely on the patient's subjective complaints without a systematic neurological examination or correlation to anatomical pathways, fails to meet the standards of diagnostic rigor expected of a PA. This could lead to a superficial understanding of the problem and potentially a misdiagnosis, violating the ethical obligation to provide competent care. It also disregards the importance of objective findings in neurological assessment, a key component of the PA's scope of practice. An approach that immediately jumps to a specific, rare diagnosis without considering more common etiologies or systematically ruling them out is not evidence-based. This can lead to confirmation bias and missed opportunities for accurate diagnosis and timely treatment of more prevalent conditions. It demonstrates a lack of systematic diagnostic reasoning, which is a critical skill assessed in recertification examinations and essential for patient safety. An approach that relies heavily on advanced imaging modalities without a clear hypothesis derived from the patient's history and physical examination is inefficient and potentially costly. While imaging is crucial in neurology, its use should be guided by clinical suspicion to maximize diagnostic yield and avoid unnecessary procedures. This approach fails to demonstrate the foundational neuroanatomical and physiological understanding required to formulate such a hypothesis, which is a core expectation for recertification. Professional reasoning. Professionals should employ a systematic approach to neurological assessment and diagnosis. This involves 1. Obtaining a thorough history including the nature, onset, and progression of symptoms. 2. Performing a comprehensive physical and neurological examination, including specific tests to evaluate cranial nerves, motor function, sensory pathways, reflexes, and coordination. 3. Integrating the findings from the history and physical examination to formulate a differential diagnosis based on neuroanatomical localization and physiological principles. 4. Utilizing diagnostic studies judiciously to confirm or refute the differential diagnosis. And 5. Developing and implementing an evidence-based treatment plan. This structured reasoning process ensures that all relevant information is considered, leading to the most accurate and efficient diagnosis and management. Question 5. Examination of the data shows a 65-year-old male with a history of hypertension and migraines presenting to the emergency department with sudden onset of right-sided weakness and difficulty speaking that began approximately 2 hours prior to arrival. He denies any recent trauma or fever. His last migraine episode was 2 weeks ago and resolved without residual symptoms. Which of the following represents the most appropriate initial management approach? Option A. Order an MRI of the brain to evaluate for chronic white matter changes and potential migraine-related sequelae. Option B. Administer intravenous thrombolytics after confirming eligibility criteria and obtaining appropriate imaging. Option C. Prescribe a high-dose triptan medication and schedule follow-up with neurology in 1 week. Option D. Provide symptomatic relief with analgesics and antiemetics and advise the patient to rest at home. Correct answer is B. Administer intravenous thrombolytics after confirming eligibility criteria and obtaining appropriate imaging. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with a history of neurological events, requiring the PA to differentiate between acute symptoms and chronic sequelae, while also considering potential new pathologies. The urgency of neurological symptoms necessitates rapid and accurate assessment to prevent long-term disability or life-threatening complications. The PA must integrate patient history, physical examination findings, and diagnostic data to formulate an appropriate management plan, adhering to established clinical guidelines and scope of practice. Correct approach analysis. The correct approach involves a systematic evaluation that prioritizes ruling out emergent conditions. This aligns with best professional practice by ensuring patient safety and timely intervention. For a patient presenting with new neurological deficits, immediate assessment for stroke is paramount. This includes a focused neurological exam, vital signs, and consideration of neuroimaging, e.g., CT scan, to identify acute ischemic or hemorrhagic stroke. Prompt recognition and treatment of stroke can significantly improve outcomes. This approach is supported by the NCCPA emphasis on evidence-based practice and the PA's responsibility to provide high-quality patient care within their scope of practice, which includes the diagnosis and management of common neurological disorders. Incorrect approach is analysis. One incorrect approach would be to attribute all new symptoms solely to the patient's known history of migraines without a thorough workup. This fails to acknowledge the potential for a new, emergent condition like a stroke, which could lead to delayed diagnosis and treatment, resulting in irreversible neurological damage. This represents a failure to adhere to the principle of do no harm and a deviation from best practice in neurological assessment. Another incorrect approach would be to manage the patient solely with symptomatic treatment for migraine, e.g., analgesics, antiemetics, without considering other differential diagnoses. This overlooks the critical need to investigate new neurological deficits, potentially missing a treatable cause and violating the standard of care for evaluating such presentations. A third incorrect approach might involve prematurely discharging the patient with instructions for follow-up in a week without further investigation, assuming the symptoms are benign or related to post-migraine phenomena. This is professionally unacceptable as it neglects the potential for a serious underlying pathology that requires immediate attention and could lead to significant patient harm. Professional reasoning. Professionals should approach such cases with a high index of suspicion for emergent conditions. The decision-making process should involve 1. Rapidly assessing the ABCs and vital signs. 2. Performing a detailed neurological examination, including assessment of cranial nerves, motor and sensory function, coordination and gait. 3. Obtaining a thorough history, focusing on the onset, duration, character, and associated symptoms of the current complaint, as well as past medical history, medications, and risk factors. 4. Developing a differential diagnosis that includes emergent conditions, stroke, seizure, intracranial hemorrhage, and less emergent but significant conditions, migraine variants, transient ischemic attack, peripheral neuropathy. 5. Ordering appropriate diagnostic tests, e.g., neuroimaging laboratory studies, based on the differential diagnosis and clinical presentation. 6. Initiating prompt management based on the diagnosis, including consideration of time-sensitive interventions for conditions like stroke. 7. Ensuring clear communication with the patient and family regarding the assessment, plan, and potential outcomes. Question 6. Performance analysis shows that a 55-year-old male presents with fatigue, weight gain, and intermittent palpitations. He reports increased thirst and urination over the past month, but denies any recent illness or medication changes. His past medical history is significant for hypertension. What is the most appropriate initial diagnostic strategy to evaluate these symptoms? Option A. Order a fasting plasma glucose, HbA1c, and a TSH level. Option B. Immediately order a comprehensive metabolic panel, cortisol level, and thyroid ultrasound. Option C. Initiate empiric treatment for hypothyroidism and schedule a follow-up appointment in 6 weeks. Option D. Focus solely on evaluating for diabetes mellitus with a fasting plasma glucose and urine dipstick. The correct answer is A. Order a fasting plasma glucose, HbA1c, and a TSH level. Explanation. Scenario analysis. This scenario presents a common challenge in endocrine management where a patient exhibits symptoms suggestive of multiple endocrine disorders, requiring a systematic diagnostic approach to differentiate and manage effectively. The challenge lies in the overlapping nature of symptoms and the need to prioritize investigations based on clinical presentation and potential severity, all while adhering to evidence-based guidelines and the scope of practice for physician assistants, PA, as defined by the NCCPA and relevant state boards. Correct approach analysis. The correct approach involves a thorough history and physical examination to gather comprehensive data, followed by targeted laboratory investigations to confirm or rule out specific endocrine disorders. This aligns with best professional practice by utilizing a systematic, evidence-based diagnostic process. Specifically, initial screening for diabetes mellitus with HbA1c and fasting glucose is appropriate given the prevalence and potential acute complications. Concurrently, assessing thyroid function with TSH is crucial due to the commonality of thyroid dysfunction and its impact on metabolism and energy levels, which can mimic other endocrine issues. If these initial tests are inconclusive, or if clinical suspicion remains high for adrenal insufficiency, further specific testing like morning cortisol levels would be indicated. This tiered approach minimizes unnecessary testing, reduces patient burden, and ensures efficient resource utilization, all within the PA's scope of practice and ethical obligations to provide competent care. Incorrect approach is analysis. One incorrect approach would be to immediately order a broad panel of specialized endocrine tests without a clear clinical rationale or initial screening. This is professionally unacceptable, as it represents a lack of systematic diagnostic reasoning, potentially leading to unnecessary costs, patient anxiety, and the risk of incidental findings that may not be clinically significant. It fails to adhere to the principle of judicious use of diagnostic resources and may exceed the expected diagnostic workup for initial presentation. Another incorrect approach would be to focus solely on one suspected diagnosis, e.g., only diabetes, and defer investigation of other potential endocrine issues despite suggestive symptoms. This is a failure of comprehensive clinical assessment and can lead to delayed diagnosis and management of other serious conditions, such as thyroid disorders or adrenal insufficiency, potentially resulting in adverse patient outcomes and a breach of the PA's duty of care. A third incorrect approach would be to rely solely on patient self-reported symptoms without objective diagnostic confirmation. While patient history is vital, definitive diagnosis of endocrine disorders requires objective laboratory data. Proceeding with treatment based solely on subjective complaints without appropriate diagnostic workup is professionally unsound and can lead to misdiagnosis and inappropriate therapy, violating ethical standards of evidence-based practice. Professional reasoning. Professionals should approach such cases by first establishing a differential diagnosis based on the patient's presenting symptoms and medical history. This should be followed by a stepwise diagnostic plan, starting with the most common and potentially serious conditions, utilizing appropriate screening tests before proceeding to more specialized or invasive investigations. Throughout this process, PAs must remain within their scope of practice, consult with supervising physicians when necessary, and adhere to established clinical practice guidelines and ethical principles of patient care, including informed consent and judicious resource management. Question 7. The monitoring system demonstrates a significant and sustained elevation in pancreatic enzymes, consistent with acute pancreatitis, in a patient who has previously expressed a strong desire to avoid hospitalization and invasive procedures. The patient, who is alert and oriented, states, "I understand what you're saying, but I don't want any more tubes or needles. I want to go home." What is the most appropriate next step for the physician assistant? Option A. Proceed with initiating intravenous fluid resuscitation and pain management without further discussion, as the clinical findings necessitate immediate intervention. Option B. Immediately contact the patient's family to explain the severity of the situation and request their assistance in convincing the patient to accept hospitalization and treatment. Option C. Engage in a detailed discussion with the patient about the risks of refusing further evaluation and potential treatment. Explore the reasons behind their strong aversion to hospitalization and procedures, and offer alternative management strategies if appropriate and safe, while respecting their autonomy if they maintain their decision after full understanding. Option D. Document the patient's refusal of care and discharge them home with instructions to return if symptoms worsen, without further discussion of risks or alternatives. The correct answer is C. Engage in a detailed discussion with the patient about the risks of refusing further evaluation and potential treatment. Explore the reasons behind their strong aversion to hospitalization and procedures, and offer alternative management strategies if appropriate and safe, while respecting their autonomy if they maintain their decision after full understanding. Explanation. Scenario analysis. This scenario presents a professional challenge due to the conflict between a patient's expressed wishes and the clinical findings suggesting a potentially life-threatening condition. The PA must balance patient autonomy with the ethical and legal obligation to provide appropriate care and prevent harm. The urgency of the situation, indicated by the monitoring system, necessitates swift and informed decision-making. Correct approach analysis. The correct approach involves a thorough clinical assessment to confirm the findings, followed by a direct and empathetic discussion with the patient about the risks and benefits of further investigation and treatment. This aligns with the NCCPA emphasis on patient-centered care, informed consent, and the PA's role in advocating for patient well-being within the scope of practice. The PA's responsibility is to ensure the patient understands the potential consequences of their refusal, while respecting their right to make decisions about their own body, even if those decisions are not what the clinician would recommend. This approach upholds the ethical principles of beneficence, acting in the patient's best interest, and autonomy, respecting the patient's right to self-determination. Incorrect approach is analysis. One incorrect approach would be to immediately override the patient's wishes and proceed with invasive procedures without further discussion or attempting to understand the patient's reasoning. This violates the principle of patient autonomy and informed consent, which are fundamental to medical ethics and professional practice. It could also lead to a breakdown in the patient-provider relationship and potential legal repercussions. Another incorrect approach would be to simply document the patient's refusal and withdraw care, without exploring the underlying reasons for their decision or offering alternative solutions or support. This fails to fulfill the PA's duty of care and could be seen as abandonment, especially if the patient's refusal stems from fear, misunderstanding, or a lack of trust. It neglects the ethical obligation to explore all avenues to ensure the patient receives the best possible care within the bounds of their autonomy. A third incorrect approach would be to involve family members or other healthcare providers in making the decision for the patient without the patient's explicit consent or involvement, unless the patient lacks decision-making capacity. While collaboration is important, the primary decision maker, if capable, is the patient. Circumventing the patient's direct involvement undermines their autonomy and could lead to ethical and legal complications. Professional reasoning. Professionals should approach such dilemmas by first ensuring they have accurate and complete clinical data. Then they must engage in open and honest communication with the patient, actively listening to their concerns and providing clear, understandable information about their condition, treatment options, and potential outcomes. The decision-making process should be collaborative, empowering the patient to make an informed choice while ensuring the PA has met their ethical and legal obligations to inform and advise. If the patient's decision-making capacity is in question, a formal assessment of capacity should be undertaken. Question 8. Analysis of a patient presenting with a persistent cough and fatigue who has researched online and is now requesting a chest X-ray, spirometry, and a CT scan of the chest presents an ethical dilemma for the physician assistant. The PA has performed a thorough physical examination and obtained a detailed history, but based on the initial findings, believes a chest X-ray is the most appropriate initial diagnostic step, with spirometry and CT scan being considered only if the X-ray is inconclusive or reveals specific findings. How should the PA proceed to ethically and professionally manage this situation? Option A. Explain the clinical rationale for starting with a chest X-ray, discuss the potential benefits and risks of all requested tests, and collaboratively decide on the initial diagnostic plan with the patient, emphasizing that further testing will be considered based on the X-ray results. Option B. Refuse to order any diagnostic tests, stating that the patient's requests are based on unsubstantiated online information and that the PA's clinical judgment is sufficient. Option C. Order all 3 requested diagnostic tests immediately to satisfy the patient's request and avoid potential conflict. Option D. Order a CT scan of the chest as it is the most comprehensive imaging test, and then proceed with other requested tests if deemed necessary after the CT scan. The correct answer is A. Explain the clinical rationale for starting with a chest X-ray, discuss the potential benefits and risks of all requested tests, and collaboratively decide on the initial diagnostic plan with the patient, emphasizing that further testing will be considered based on the X-ray results. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the PA's clinical judgment regarding the necessity and appropriateness of diagnostic testing. The PA must navigate patient autonomy, beneficence, and non-maleficence while adhering to professional standards and regulatory guidelines. The core of the challenge lies in determining when to defer to patient preference versus when to assert clinical expertise to ensure optimal patient care and avoid unnecessary or potentially harmful interventions. The correct approach represents best professional practice because it prioritizes patient well-being and informed decision-making. By engaging in a thorough discussion about the risks, benefits, and alternatives of each diagnostic test, the PA empowers the patient to make an informed choice that aligns with their values and understanding, while also ensuring the patient comprehends the clinical rationale behind the recommended tests. This approach upholds the ethical principles of autonomy and beneficence, and aligns with PA practice acts that emphasize collaborative decision-making and patient education. An incorrect approach that involves unilaterally ordering all requested tests without adequate assessment or discussion fails to uphold the principle of non-maleficence. Ordering tests that are not clinically indicated can lead to unnecessary patient anxiety, financial burden, and potential harm from false positives or complications of invasive procedures. This also disregards the PA's professional responsibility to practice evidence-based medicine. Another incorrect approach, that of refusing to order any tests and dismissing the patient's concerns, violates the principle of beneficence and patient autonomy. It fails to acknowledge the patient's subjective experience and their right to participate in their healthcare decisions. This can erode patient trust and lead to suboptimal care. A further incorrect approach, that of ordering tests solely based on the patient's request without any clinical justification or discussion, represents a failure to exercise professional judgment and adhere to the standards of care. This can lead to misdiagnosis, delayed appropriate treatment, and a waste of healthcare resources. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly assess the patient's symptoms and medical history to establish a differential diagnosis. Second, discuss the patient's concerns and their understanding of their condition. Third, explain the rationale for recommended diagnostic tests, including their potential benefits, risks, and alternatives, in a clear and understandable manner. Fourth, collaboratively decide on a diagnostic plan, respecting the patient's informed choices while ensuring the plan is clinically sound and ethically justifiable. Finally, document the patient encounter, including the discussion, decision-making process, and the agreed-upon plan. Question 9. Compliance review shows a 45-year-old male presenting to the emergency department with acute onset of severe shortness of breath, wheezing, and chest tightness. He has a history of asthma, for which he uses an albuterol inhaler as needed. His vital signs are blood pressure 130/85 mmHg, heart rate 110 bpm, respiratory rate 30 breaths/min, and oxygen saturation 88% on room air. Physical examination reveals diffuse expiratory wheezing bilaterally and diminished breath sounds in the bases. Which of the following initial management strategies is most appropriate for this patient? Option A. Administer supplemental oxygen to maintain saturation above 90% and provide a prescription for a short course of oral prednisone to be started at home. Option B. Administer supplemental oxygen to maintain saturation above 90% and provide a prescription for a rescue inhaler refill. Option C. Administer supplemental oxygen to maintain saturation above 90%, nebulized albuterol and ipratropium, and intravenous methylprednisolone. Option D. Administer supplemental oxygen to maintain saturation above 90% and initiate a chest X-ray to rule out pneumonia before any bronchodilator therapy. Correct answer is C. Administer supplemental oxygen to maintain saturation above 90%, nebulized albuterol and ipratropium, and intravenous methylprednisolone. Explanation. This scenario presents a common yet critical challenge in emergency medicine: the rapid assessment and management of a patient with acute respiratory distress. The professional challenge lies in the need for swift, accurate diagnosis and intervention, while navigating potential underlying etiologies and patient comorbidities. The urgency of the situation demands a systematic approach that prioritizes life-sustaining measures and evidence-based treatment. The correct approach represents best professional practice by adhering to established clinical guidelines for asthma exacerbation management, as promulgated by organizations like the National Asthma Education and Prevention Program, NEP, and reflected in PA Practice Acts and scope of practice regulations. This involves immediate administration of short-acting beta agonists, SABA, and systemic corticosteroids, which directly address the bronchoconstriction and inflammation characteristic of asthma. Oxygen therapy is crucial to correct hypoxemia, and continuous monitoring of vital signs and response to treatment is essential for guiding further management. This aligns with the PA's responsibility to provide competent care within their scope of practice, as defined by state boards of medicine and NCCPA guidelines for recertification. An incorrect approach of solely administering a bronchodilator without considering systemic corticosteroids fails to address the underlying inflammatory process, potentially leading to a prolonged or severe exacerbation. This could be considered a deviation from standard of care and a failure to practice competently, potentially violating state practice acts that mandate adherence to accepted medical standards. Another incorrect approach of delaying definitive treatment to await further diagnostic imaging without initial stabilization would be a critical failure in managing an acute, life-threatening condition, contravening the ethical imperative to act in the patient's best interest and potentially violating regulations regarding timely patient care. Finally, an approach that focuses on non-pharmacological interventions without addressing the immediate pharmacological needs of bronchospasm and inflammation would be a significant departure from evidence-based practice and could be deemed negligent. Professional decision-making in such situations requires a rapid assessment of the patient's airway, breathing, and circulation, ABCs, followed by a differential diagnosis based on presenting symptoms and history. The PA must then apply knowledge of pathophysiology and pharmacotherapy to initiate appropriate interventions, continuously reassessing the patient's response and adjusting the treatment plan accordingly. This process is guided by clinical protocols, evidence-based guidelines, and the PA's scope of practice, all of which are foundational to maintaining licensure and recertification. Question 10. The control framework reveals that when a patient presents with symptoms suggestive of endocrine dysfunction, such as fatigue and weight changes, what is the most appropriate initial diagnostic step for evaluating potential thyroid pathology? Option A. Order a thyroid-stimulating hormone TSH level. Option B. Order a broad panel of various hormone assays. Option C. Rely solely on the patient's reported symptoms for diagnosis. Option D. Order a comprehensive metabolic panel, CMP. The correct answer is A. Order a thyroid-stimulating hormone TSH level. Explanation. The control framework reveals that a physician assistant PA must adhere to established guidelines for ordering and interpreting diagnostic tests, particularly those involving endocrine function, to ensure patient safety and appropriate management. This scenario is professionally challenging because it requires the PA to integrate knowledge of patient history, current symptoms, and the specific indications for various endocrine tests, while also considering the potential for misinterpretation or over-reliance on isolated results. The PA must exercise sound clinical judgment to determine the most appropriate diagnostic pathway and avoid unnecessary or potentially misleading investigations. The correct approach represents best professional practice because it prioritizes a systematic and evidence-based diagnostic process. Ordering a thyroid-stimulating hormone, TSH, level is the initial, most sensitive screening test for primary thyroid dysfunction. If the TSH is abnormal, further testing, such as free T4, is indicated to differentiate between primary and secondary causes and to assess the severity of the dysfunction. This tiered approach is cost-effective and aligns with established clinical practice guidelines for thyroid evaluation, ensuring that diagnostic efforts are focused and relevant to the patient's presentation. This adheres to the PA's scope of practice and the expectation of providing evidence-based care as outlined by the NCCPA and relevant state practice acts. An incorrect approach would be to order a comprehensive metabolic panel, CMP, with the expectation that it would directly diagnose thyroid dysfunction. While a CMP can provide general information about electrolyte balance, kidney function, and liver function, it does not directly assess thyroid hormone levels. This approach represents a failure to utilize appropriate diagnostic tools for the suspected condition, potentially leading to delayed diagnosis and inappropriate patient management. It also demonstrates a lack of understanding of the specific diagnostic pathways for endocrine disorders, which is a core competency for PAs. Another incorrect approach would be to order a panel of multiple hormone assays without a clear clinical indication or hypothesis. This shotgun approach is not cost-effective, can lead to the discovery of incidental findings that may not be clinically significant, and can cause patient anxiety. It deviates from the principle of judicious test ordering, and can be considered a deviation from professional standards of care, potentially violating guidelines related to resource utilization and patient-centered care. A third incorrect approach would be to rely solely on patient-reported symptoms without objective laboratory confirmation for a suspected endocrine disorder. While symptoms are crucial for guiding the diagnostic process, definitive diagnosis of conditions like hypothyroidism or hyperthyroidism requires objective laboratory data. This approach risks misdiagnosis and inappropriate treatment, failing to meet the standard of care that mandates objective diagnostic confirmation for significant medical conditions. The professional reasoning process should involve a thorough patient history and physical examination to formulate a differential diagnosis. Based on the differential, the PA should then select the most appropriate and cost-effective diagnostic tests that will confirm or refute the suspected conditions. This involves understanding the sensitivity, specificity, and clinical utility of various laboratory investigations, and ordering them in a logical, stepwise manner when indicated. Adherence to established clinical practice guidelines and consultation with supervising physicians when necessary are also critical components of sound professional decision-making. Question 11. Research into the evaluation of a 65-year-old male presenting with new-onset exertional dyspnea, chest tightness with exertion, and a history of hypertension and hyperlipidemia indicates a need for a diagnostic workup. Considering the patient's risk factors and symptoms, which of the following diagnostic approaches best aligns with current best practices for assessing potential cardiac ischemia? Option A. Initiate a comprehensive cardiac risk stratification including a detailed history, physical examination, and an electrocardiogram (ECG) to assess for baseline abnormalities, followed by consideration of further non-invasive testing such as a stress test if indicated by the initial assessment. Option B. Proceed directly to a stress echocardiogram to evaluate for wall motion abnormalities during exercise. Option C. Immediately schedule the patient for a coronary angiography to definitively assess for significant coronary artery disease. Option D. Order a chest X-ray and a complete blood count, CBC, to rule out pulmonary and hematologic causes of dyspnea. The correct answer is A. Initiate a comprehensive cardiac risk stratification including a detailed history, physical examination, and an electrocardiogram (ECG) to assess for baseline abnormalities, followed by consideration of further non-invasive testing such as a stress test if indicated by the initial assessment. Explanation. This scenario presents a professional challenge due to the need to balance diagnostic accuracy with patient safety and resource utilization when evaluating a patient with new-onset exertional dyspnea. The physician assistant, PA, must consider the most appropriate diagnostic pathway based on the patient's presentation and risk factors, adhering to established clinical guidelines and the scope of practice. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation that begins with a thorough history and physical examination to stratify risk. This allows for the selection of diagnostic tests that are most likely to yield relevant information, while minimizing unnecessary procedures and associated risks. Adherence to guidelines from professional organizations, such as those pertaining to cardiovascular disease, ensures that diagnostic decisions are aligned with current medical knowledge and best practices, promoting patient well-being and efficient healthcare delivery. This aligns with the PA's ethical obligation to provide competent and appropriate care. An incorrect approach that immediately orders a stress echocardiogram without a prior risk stratification or consideration of less invasive options fails to adhere to a prudent diagnostic strategy. This could lead to unnecessary costs, patient discomfort, and potential risks associated with the procedure itself, without a clear indication based on the initial clinical assessment. It may also represent a failure to utilize resources judiciously, which is an implicit ethical consideration in healthcare. Another incorrect approach, such as solely relying on a chest X-ray for new-onset exertional dyspnea without further cardiac evaluation, might miss critical underlying cardiac pathology. This could result in delayed diagnosis and treatment of potentially serious conditions, violating the PA's duty to provide comprehensive and effective care. A further incorrect approach, such as ordering a coronary angiography as a first-line diagnostic test for exertional dyspnea in a patient without significant pretest probability of severe coronary artery disease, is inappropriate. Coronary angiography is an invasive procedure with inherent risks and is typically reserved for patients with a higher likelihood of significant coronary artery disease based on clinical presentation and non-invasive testing. Proceeding directly to such an invasive test without appropriate justification represents a failure to follow a stepwise diagnostic approach and could expose the patient to undue risk. The professional reasoning process for similar situations involves a systematic approach. 1. Thoroughly gather patient history and perform a comprehensive physical examination to identify signs and symptoms suggestive of specific etiologies. 2. Stratify the patient's risk for serious underlying conditions based on established clinical criteria and guidelines. 3. Select diagnostic tests that are appropriate for the patient's risk profile and clinical presentation, prioritizing non-invasive and less risky options first. 4. Consider the potential benefits, risks, and costs of each diagnostic test. 5. Consult with supervising physicians or specialists when indicated. 6. Document the rationale for all diagnostic and treatment decisions. Question 12. Risk assessment procedures indicate a 45-year-old patient presents with insidious onset of right shoulder pain, primarily exacerbated by overhead activities, and at night. The patient reports a gradual decrease in the ability to abduct and externally rotate the arm. Physical examination reveals mild tenderness over the anterior deltoid and supraspinatus insertion, with pain but no significant weakness noted during resisted abduction and external rotation. Passive range of motion is full, but elicits discomfort in the extreme ranges. Which of the following diagnostic and management approaches best reflects a comprehensive risk assessment for this patient's musculoskeletal complaint? Option A. Focus on palpating for Gros joint effusion or crepitus and prescribing muscle relaxants to address any perceived muscle guarding. Option B. Initiate a course of non-steroidal anti-inflammatory drugs, NSAID, and recommend rest, with a follow-up appointment scheduled in 4 weeks to reassess symptoms. Option C. Perform a detailed assessment of shoulder girdle anatomy and physiology, including specific provocative tests for rotator cuff impingement and tears, and consider imaging such as ultrasound or MRI if clinical suspicion remains high after the physical examination. Option D. Advise the patient that the symptoms are likely due to age-related degenerative changes, and recommend over-the-counter pain relievers and stretching exercises. The correct answer is B. Initiate a course of non-steroidal anti-inflammatory drugs, NSAID, and recommend rest, with a follow-up appointment scheduled in 4 weeks to reassess symptoms. Explanation. Scenario analysis. This scenario presents a professional challenge due to the potential for misdiagnosis and delayed appropriate treatment stemming from a patient's subjective reporting of pain and limited objective findings. The PA must synthesize subtle anatomical and physiological cues with the patient's history to formulate a differential diagnosis and initiate a safe and effective management plan, adhering to established standards of care for musculoskeletal conditions. Correct approach analysis. The correct approach involves a systematic and comprehensive evaluation of the patient's musculoskeletal complaint, integrating anatomical knowledge of the shoulder girdle and rotator cuff with physiological principles of muscle function and joint mechanics. This includes a thorough history, targeted physical examination maneuvers to assess range of motion, strength, and pain provocation, and consideration of potential differential diagnoses. This aligns with the Physician Assistant National Recertifying Examination's emphasis on clinical reasoning and evidence-based practice, ensuring patient safety and optimal outcomes by avoiding premature conclusions and pursuing a diagnostic pathway that addresses the most likely etiologies. Incorrect approaches analysis. An approach that immediately attributes the pain to a simple strain without further investigation fails to acknowledge the complexity of shoulder anatomy and the potential for more serious underlying pathology, such as rotator cuff tears or impingement syndrome. This could lead to delayed diagnosis and treatment, violating the ethical obligation to provide competent care and potentially contravening guidelines for musculoskeletal assessment. An approach that focuses solely on pain management without a thorough diagnostic workup overlooks the underlying anatomical or physiological derangement causing the pain. This is ethically problematic as it treats a symptom rather than the cause, potentially masking a progressive condition and failing to meet the standard of care for a comprehensive patient evaluation. An approach that dismisses the patient's symptoms due to a lack of significant objective findings on initial palpation neglects the nuances of musculoskeletal injuries. Many conditions, particularly early-stage rotator cuff issues or impingement, may not present with gross deformities or obvious tenderness, but can be elicited through specific provocative tests. This approach risks invalidating patient experience and failing to identify pathology, which is a failure in professional duty of care. Professional reasoning. Professionals should employ a structured approach to musculoskeletal complaints, beginning with a detailed history to understand the onset, character, location, and aggravating/alleviating factors of the pain. This should be followed by a systematic physical examination, including observation, palpation, assessment of active and passive range of motion, muscle strength testing, and specific provocative maneuvers relevant to the suspected joint or region. A broad differential diagnosis should be considered, and diagnostic imaging or further consultations pursued as indicated by the clinical findings and the patient's presentation. This iterative process of assessment, diagnosis, and management ensures that patient care is both safe and effective. Question 13. Benchmark analysis indicates that a 72-year-old male with a history of hypertension, coronary artery disease (CAD), status post-myocardial infarction, and chronic systolic heart failure (NIHA class Roman II), presents with a 3-day history of increasing shortness of breath, particularly with exertion, and bilateral lower extremity edema. He reports a 5-pound weight gain over the past week and occasional non-productive cough at night. His current medications include lisinopril, metoprolol, furosemide, and aspirin. Which of the following approaches best reflects current best practices for managing this patient? Option A. Prescribe a short course of oral corticosteroids to reduce inflammation and improve respiratory symptoms. Option B. Recommend a low-dose beta blocker to improve cardiac contractility and manage his hypertension. Option C. Initiate intravenous furosemide and consider adding a vasodilator while closely monitoring vital signs and urine output. Option D. Advise the patient to reduce his sodium intake and increase his daily furosemide dose by 20 mg, with a follow-up appointment in 2 weeks. Correct answer is C. Initiate intravenous furosemide and consider adding a vasodilator while closely monitoring vital signs and urine output. Explanation. Scenario analysis. This scenario presents a common clinical challenge involving a patient with multiple cardiovascular risk factors and symptoms suggestive of worsening heart failure. The professional challenge lies in accurately assessing the patient's current status, differentiating between exacerbation of chronic conditions and new acute issues, and formulating an evidence-based management plan that aligns with current guidelines and patient-specific factors, all while adhering to the scope of practice for a physician-assistant PA within the U.S. regulatory framework. The need for timely and appropriate intervention is paramount to prevent further morbidity and mortality. Correct approach analysis. The correct approach involves a comprehensive assessment that includes a detailed history, thorough physical examination, and judicious use of diagnostic tools to evaluate for signs of fluid overload, cardiac dysfunction, and potential precipitating factors for heart failure exacerbation. This aligns with best professional practice as outlined by the NCCPA, National Commission on Certification of Physician Assistants, and PA Practice Acts, emphasizing the PA's role in patient assessment, diagnosis, and management. Specifically, it reflects the PA's responsibility to gather sufficient data to formulate a differential diagnosis and treatment plan, prioritizing patient safety and evidence-based care. This approach ensures that the management is tailored to the individual patient's needs and current clinical presentation, adhering to the principles of patient-centered care and the collaborative practice model. Incorrect approaches analysis. An approach that solely focuses on prescribing a diuretic without a thorough assessment of the patient's volume status, electrolyte balance, renal function, and potential underlying causes of fluid retention would be a regulatory and ethical failure. This bypasses the essential diagnostic steps required for safe and effective management, potentially leading to adverse effects like electrolyte imbalances or dehydration, and failing to address the root cause of the patient's symptoms. It deviates from the PA's responsibility to conduct a comprehensive evaluation before initiating treatment. Another incorrect approach would be to dismiss the patient's symptoms as solely due to aging or minor fluctuations in chronic conditions without further investigation. This constitutes a failure to meet the standard of care and could lead to delayed diagnosis and treatment of a serious condition like acute decompensated heart failure. Ethically, it represents a dereliction of duty to adequately assess and manage a patient presenting with concerning symptoms. An approach that involves initiating aggressive antihypertensive therapy without considering the patient's current blood pressure, heart rate, and signs of heart failure would also be professionally unacceptable. This could lead to hypotension, reduced cardiac output, and worsening of heart failure symptoms. It demonstrates a lack of critical thinking and adherence to evidence-based guidelines for managing cardiovascular disease in the context of heart failure. Professional reasoning. Professionals should approach such a scenario by first recognizing the potential seriousness of the patient's symptoms, especially given their history of cardiovascular disease. The decision-making process should involve a systematic evaluation. 1. Gather comprehensive subjective data. Focus on changes in symptoms, duration, severity, and any potential precipitating factors. 2. Perform a targeted physical examination. Assess vital signs, lung sounds, cardiac auscultation, peripheral edema, and jugular venous distension. 3. Consider appropriate diagnostic studies. This may include laboratory tests, e.g., BNP, electrolytes, renal function, electrocardiogram (ECG), and chest X-ray. 4. Formulate a differential diagnosis. Consider acute decompensated heart failure, worsening hypertension, or other potential causes. 5. Develop a management plan. This should be evidence-based, individualized, and consider the patient's overall clinical picture, including medication reconciliation and potential adjustments. 6. Collaborate with supervising physician. As per PA Practice Acts, consultation and collaboration are crucial for complex cases. 7. Educate the patient. Ensure understanding of the diagnosis, treatment plan, and warning signs. This structured approach ensures that patient care is safe, effective, and compliant with regulatory requirements and ethical standards. Question 14. Which approach would be most appropriate for a physician assistant to initiate when evaluating a patient presenting to the emergency department with sudden onset of left-sided weakness, facial droop, and slurred speech? Option A, lumbar puncture. Option B, CT myelogram of the spine. Option C, computed tomography CT scan of the head without contrast. Option D, magnetic resonance imaging MRI of the brain. The correct answer is C, computed tomography CT scan of the head without contrast. Explanation: scenario analysis. This scenario presents a common clinical challenge where a physician assistant, PA, must judiciously select the most appropriate diagnostic imaging modality for a patient with suspected neurological compromise. The challenge lies in balancing diagnostic yield, patient safety, resource utilization, and adherence to established clinical guidelines and regulatory expectations for PA practice. The PA must consider the specific clinical presentation, potential differential diagnoses, and the unique advantages and limitations of each imaging technique. Correct approach analysis. The correct approach prioritizes a non-invasive, readily available, and highly sensitive imaging modality for initial evaluation of acute neurological deficits, particularly when stroke is a primary concern. CT of the head without contrast is the standard of care in the emergency department for evaluating acute stroke symptoms. It is rapid, widely accessible, and excellent at detecting acute intracranial hemorrhage, which is a critical contraindication for thrombolytic therapy. This aligns with the PA's scope of practice and the expectation to provide timely and evidence-based care within the established regulatory framework for PAs in the United States, which emphasizes patient safety and appropriate utilization of diagnostic resources. Incorrect approaches analysis. Ordering an MRI of the brain without first considering a CT scan is often not the most appropriate initial step in an acute neurological deficit presentation. While MRI offers superior soft tissue detail and can detect ischemic changes earlier than CT, it is typically more time-consuming, less readily available in emergent settings, and may not be as effective at ruling out acute hemorrhage. This could lead to delays in critical treatment decisions, potentially violating the principle of providing prompt and effective care as expected under PA regulations. Performing a lumbar puncture as the initial diagnostic test for acute neurological deficits, especially when stroke is suspected, is generally inappropriate and potentially dangerous. Lumbar puncture carries risks, including the potential for herniation if there is a significant intracranial mass or increased intracranial pressure, which might not be immediately evident on physical exam alone. It is not the primary modality for evaluating acute stroke or most other acute neurological emergencies. This approach would represent a failure to adhere to established diagnostic algorithms and patient safety protocols, which are implicitly or explicitly governed by PA Practice Acts and professional standards. Ordering a CT myelogram without a clear indication for spinal canal pathology is an invasive procedure that is not indicated for the initial evaluation of acute neurological deficits suggestive of a cerebrovascular event or other common emergent neurological conditions. This would represent an unnecessary escalation of diagnostic testing, potentially exposing the patient to risks associated with contrast agents and radiation, without a justifiable clinical rationale, which contravenes the principles of prudent resource management and patient care expected of PAs. Professional reasoning. When faced with a patient presenting with acute neurological deficits, the PA should employ a systematic approach. First, conduct a thorough history and physical examination to narrow the differential diagnosis. Second, consider the most likely emergent conditions and the diagnostic modalities best suited to rule them in or out rapidly and safely. Third, consult established clinical guidelines and protocols for the suspected condition. Fourth, consider the availability and logistical feasibility of diagnostic tests in the clinical setting. Finally, document the rationale for all diagnostic decisions. This structured approach ensures that patient care is evidence-based, safe, and efficient, aligning with the responsibilities and expectations placed upon PAs by regulatory bodies. Question 15. The review process indicates a 68-year-old patient presence with a several-week history of worsening right knee pain, particularly with weight-bearing and stair climbing. The patient denies any specific injury, but reports stiffness in the morning that improves with movement. Physical examination reveals mild crepitus with flexion and extension, mild tenderness over the medial joint line, and full range of motion without significant effusion or instability. Which of the following represents the most appropriate initial management approach? Option A. Refer the patient immediately for an MRI of the right knee to assess for meniscal or ligamentous pathology. Option B. Prescribe a short course of oral corticosteroids and recommend rest for 1 week. Option C. Advise the patient that knee pain is a common symptom of aging and recommend over-the-counter pain relievers as needed. Option D. Order bilateral knee X-rays, including weight-bearing anterior-posterior and lateral views, and schedule a follow-up appointment to discuss results and initiate conservative management. The correct answer is D. Order bilateral knee X-rays, including weight-bearing anterior-posterior and lateral views, and schedule a follow-up appointment to discuss results and initiate conservative management. Explanation. This scenario presents a common challenge in musculoskeletal care, differentiating between acute injury and chronic degenerative processes, and determining the most appropriate initial management. Professional challenge lies in accurately assessing the patient's symptoms, considering their history, and applying evidence-based guidelines to avoid unnecessary interventions or delayed appropriate care. Careful judgment is required to balance conservative management with the need for timely diagnostic workup and treatment. The correct approach represents best professional practice by prioritizing a thorough history and physical examination to guide further diagnostic steps. This aligns with the Physician Assistant National Recertifying Examination's emphasis on clinical reasoning and patient-centered care, as outlined by the NCCPA Practice Analysis and Core Curriculum. A systematic approach ensures that the most likely diagnoses are considered and investigated appropriately, leading to efficient and effective patient management. This adheres to the ethical principle of beneficence by acting in the patient's best interest, and the principle of non-maleficence by avoiding unnecessary or potentially harmful interventions. An incorrect approach that immediately orders advanced imaging without a comprehensive initial assessment fails to adhere to the principle of judicious resource utilization and may lead to unnecessary patient exposure to radiation and increased healthcare costs. This could be considered a deviation from best practice guidelines that advocate for a stepwise diagnostic approach. Another incorrect approach that relies solely on patient self-report without objective physical findings risks misdiagnosis and inappropriate treatment, potentially violating the duty of care. A third incorrect approach that dismisses the patient's symptoms as solely age-related without a thorough evaluation overlooks the possibility of treatable pathology, which is contrary to the ethical obligation to provide comprehensive care. Professionals should approach such situations by first gathering a detailed history, including the onset, duration, character, and aggravating/alleviating factors of the pain. This should be followed by a comprehensive physical examination, including range of motion, palpation, special tests, and assessment of neurological function. Based on these findings, a differential diagnosis can be formulated and appropriate diagnostic tests, e.g., X-rays, MRI, laboratory studies, can be ordered judiciously. Treatment plans should then be tailored to the specific diagnosis and patient presentation, incorporating conservative measures, pharmacotherapy, and referral as indicated. Question 16. The analysis reveals a patient presenting with a persistent cough, low-grade fever, and fatigue. The patient has a history of recent travel to a tropical region. Considering the broad categories of infectious agents, which initial diagnostic strategy best aligns with a systematic and evidence-based approach to identifying the causative agent? Option A. Perform a comprehensive panel of serological tests for a wide range of viral infection, as viral etiologies are often implicated in respiratory symptoms. Option B. Obtain a detailed travel history, perform a thorough physical examination, and order targeted laboratory investigations such as sputum microscopy for acid-fast bacilli, ova, and parasites, and potentially a chest X-ray based on clinical suspicion. Option C. Initiate broad-spectrum antibiotic therapy immediately to cover common bacterial pathogens while awaiting further diagnostic results. Option D. Prescribe empiric antifungal medication, as fungal infections can present with nonspecific respiratory symptoms and are increasingly prevalent. The correct answer is C. Initiate broad-spectrum antibiotic therapy immediately to cover common bacterial pathogens while awaiting further diagnostic results. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient exhibits symptoms suggestive of an infectious process, but the specific causative agent is not immediately apparent. The professional challenge lies in accurately identifying the infectious agent to guide appropriate and timely treatment, thereby preventing disease progression, complications, and potential transmission. Misidentification or delayed diagnosis can lead to suboptimal patient outcomes and public health risks. Correct approach analysis. The correct approach involves a systematic diagnostic process that begins with a thorough patient history and physical examination, followed by targeted laboratory investigations. This aligns with the Physician Assistant National Recertifying Examination's emphasis on evidence-based practice and the application of clinical knowledge. Specifically, understanding the characteristics of common infectious agents, bacteria, viruses, fungi, parasites, allows the PA to formulate a differential diagnosis and select the most appropriate diagnostic tests. For instance, a suspected bacterial infection might prompt a Gram stain in culture, while viral etiologies might be investigated with serological tests or PCR. Fungal infections may require specific stains or cultures, and parasitic infections often necessitate microscopic examination of stool or blood. This methodical approach ensures that diagnostic resources are used efficiently and effectively, leading to accurate identification of the pathogen and subsequent appropriate management, which is a core competency for PAs. Incorrect approach is analysis, an approach that relies solely on empirical treatment without a clear diagnostic pathway is professionally unacceptable. This fails to adhere to the principle of evidence-based medicine, which is a cornerstone of PA practice. Without identifying the specific agent, treatment may be ineffective, leading to prolonged illness, development of antimicrobial resistance, particularly with bacteria, and unnecessary exposure to medications and their potential side effects. This also represents a failure to meet the standard of care expected of a healthcare professional. Another incorrect approach would be to order a broad array of diagnostic tests without a clear clinical rationale. This is inefficient, costly, and can lead to a deluge of information that may not be clinically relevant, potentially delaying diagnosis. It also fails to demonstrate sound clinical reasoning and prioritization, which are essential for effective patient care. Finally, an approach that dismisses the possibility of less common infectious agents based on initial assumptions, without considering the full differential diagnosis, is also professionally flawed. This can lead to misdiagnoses and delayed treatment for patients with unusual or opportunistic infections, potentially resulting in severe morbidity or mortality. Professional reasoning. Professionals should employ a systematic diagnostic framework. This involves 1. Gathering comprehensive patient data, history, physical exam, vital signs. 2. Developing a differential diagnosis based on the patient's presentation and knowledge of infectious agents. 3. Prioritizing diagnostic tests based on the differential diagnosis and clinical suspicion. 4. Interpreting test results in the context of the patient's clinical picture. 5. Initiating appropriate treatment based on the confirmed or highly suspected diagnosis and reassessing the patient's response to therapy. This iterative process ensures patient safety and optimal outcomes. Question 17. Benchmark analysis indicates that a 45-year-old male with a history of type 1 diabetes presents to the emergency department with a 2-day history of polyuria, polydipsia, nausea, and vomiting. He appears lethargic and his breath has a fruity odor. Initial vital signs are BP 90/50 mmHg, HR 120 bpm, RR 24 bpm, temp 37 degrees C, SpO2 96% on room air. A fingerstick glucose is 550 mg/dl. Which of the following initial management strategies is most appropriate? Option A. Administer intravenous isotonic saline, intravenous regular insulin infusion, and monitor serum electrolytes closely. Option B. Administer subcutaneous insulin and monitor blood glucose levels every 4 hours. Option C. Encourage oral fluid intake and administer oral metformin to control hyperglycemia. Option D. Administer intravenous dextrose and intravenous bicarbonate. The correct answer is A. Administer intravenous isotonic saline, intravenous regular insulin infusion, and monitor serum electrolytes closely. Explanation. Scenario analysis. This scenario presents a clinically complex situation involving a patient with a known history of type 1 diabetes experiencing symptoms suggestive of diabetic ketoacidosis, DKA. The challenge lies in the rapid assessment and initiation of appropriate management in a potentially life-threatening endocrine emergency. The patient's altered mental status and vomiting necessitate prompt intervention to prevent further deterioration, including cerebral edema and cardiovascular collapse. The PA must synthesize information from the patient's history, physical examination, and initial laboratory findings to formulate a safe and effective treatment plan, adhering to established protocols and guidelines for DKA management. Correct approach analysis. The correct approach involves immediate stabilization and treatment of DKA, which aligns with the physician-assistant national recertifying examinations, focus on evidence-based practice and patient safety within the U.S. regulatory framework. This includes initiating intravenous fluid resuscitation with isotonic saline to address dehydration and electrolyte imbalances, administering intravenous insulin to correct hyperglycemia and ketosis, and closely monitoring electrolyte levels, particularly potassium, which can shift rapidly during treatment. The prompt administration of intravenous fluids is crucial for restoring intravascular volume and improving tissue perfusion. Intravenous insulin is essential to suppress ketone production and promote glucose utilization. Close electrolyte monitoring, especially potassium, is vital due to the risk of hypokalemia during insulin therapy, which can lead to cardiac arrhythmias. This comprehensive management strategy is supported by current clinical practice guidelines for DKA, emphasizing a systematic and evidence-based approach to this critical condition. Incorrect approaches analysis. Administering oral fluids and oral antidiabetic medications would be a significant regulatory and ethical failure. Oral intake is contraindicated in DKA due to vomiting and the risk of aspiration, and oral antidiabetic agents are ineffective in addressing the underlying metabolic derangements of DKA. Delaying intravenous fluid resuscitation and insulin administration constitutes a failure to provide timely and appropriate care, potentially leading to severe complications and patient harm, violating the PA's duty to provide competent care. Administering subcutaneous insulin without initial intravenous fluid resuscitation and electrolyte correction would also be inappropriate, as it would not adequately address the profound dehydration and electrolyte abnormalities characteristic of DKA, and could lead to unpredictable absorption and efficacy. This approach fails to adhere to established protocols for managing severe hyperglycemia and ketosis. Professional reasoning. Professionals faced with a suspected endocrine emergency like DKA should employ a systematic approach. First, rapidly assess the patient's airway, breathing, and circulation, ABCs. Second, obtain a focused history and perform a physical examination to gather critical data. Third, initiate immediate interventions based on suspected diagnosis and patient stability, prioritizing intravenous access, fluid resuscitation, and appropriate pharmacotherapy. Fourth, order essential laboratory tests to confirm the diagnosis and guide ongoing management, including glucose, electrolytes, especially potassium, arterial blood gases or venous pH, and a ketone assessment. Fifth, continuously monitor the patient's response to treatment and adjust the management plan accordingly. Adherence to established clinical practice guidelines and protocols is paramount to ensure safe and effective patient care. Question 18. System analysis indicates a 45-year-old female presence with fatigue, unexplained weight gain, and persistent cold intolerance. She denies any recent changes in diet or exercise. The PA suspects a potential endocrine etiology. Which of the following diagnostic strategies best aligns with a systematic and evidence-based approach to evaluating this patient's symptoms? Option A. Immediately initiate thyroid hormone replacement therapy based on the constellation of symptoms. Option B. Focus solely on a psychiatric evaluation, assuming the symptoms are psychosomatic. Option C. Order a comprehensive metabolic panel and thyroid-stimulating hormone (TSH) level to assess for common endocrine imbalances. Option D. Refer the patient to an endocrinologist without performing any initial diagnostic workup. The correct answer is C. Order a comprehensive metabolic panel and thyroid-stimulating hormone (TSH) level to assess for common endocrine imbalances. Explanation. Scenario analysis. This scenario presents a professionally challenging situation because it requires the physician assistant PA to integrate knowledge of endocrine gland anatomy and physiology with the practical application of diagnostic reasoning in a patient presenting with vague, potentially systemic symptoms. The challenge lies in differentiating between primary endocrine dysfunction and secondary effects, or even non-endocrine causes, necessitating a systematic and evidence-based approach to diagnosis and management. The PA must consider the interconnectedness of the endocrine system and the potential for overlapping symptomatology. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a thorough and systematic evaluation of the patient's endocrine system, starting with a comprehensive history and physical examination. This aligns with the Physician Assistant National Recertifying Examination, PA-NRE, focus on clinical knowledge and application. Specifically, it involves targeted laboratory investigations based on the suspected endocrine gland involved, which is a cornerstone of evidence-based medicine and diagnostic accuracy. This approach adheres to the PA-NRE's emphasis on the PA's role in patient assessment, diagnosis, and management within their scope of practice, as defined by NCCPA guidelines and relevant state practice acts. It demonstrates a commitment to patient safety and effective care by avoiding premature conclusions and ensuring all relevant diagnostic avenues are explored. Incorrect approaches analysis. An approach that immediately focuses on a single, specific endocrine gland without a broader initial assessment is professionally unacceptable. This is because it risks overlooking other potential endocrine or non-endocrine causes of the patient's symptoms, leading to delayed or incorrect diagnosis and treatment. Such an approach fails to demonstrate comprehensive clinical reasoning, a key competency assessed by the PA-NRE. An approach that relies solely on patient self-reported symptoms without objective diagnostic testing is also professionally unacceptable. While patient history is crucial, it must be corroborated by objective findings. This failure to utilize diagnostic tools would violate professional standards of care and the PA-NRE's expectation of evidence-based practice. An approach that involves prescribing empirical treatment for a suspected endocrine disorder without definitive diagnostic confirmation is professionally unacceptable. This can lead to adverse drug reactions, mask underlying conditions, and delay appropriate management. It represents a departure from the systematic diagnostic process expected of PAs and assessed by the PA-NRE. Professional reasoning. Professionals should approach such scenarios by first gathering comprehensive subjective and objective data. This includes a detailed history of present illness, past medical history, family history, social history, and a thorough physical examination, paying close attention to signs and symptoms suggestive of endocrine dysfunction. Based on this initial assessment, the PA should formulate a differential diagnosis, prioritizing the most likely causes. Diagnostic investigations, including laboratory tests and imaging, should then be ordered strategically to confirm or refute the differential diagnosis. Treatment should be initiated based on confirmed diagnoses and in accordance with established clinical guidelines. Continuous reassessment and monitoring of the patient's response to treatment are also critical components of professional practice. Question 19. During the evaluation of a 65-year-old male presenting to the emergency department with sudden onset substernal chest pressure radiating to his left arm, accompanied by diaphoresis and mild shortness of breath, which of the following initial management strategies best aligns with the principles of emergency management of acute coronary syndrome and risk assessment? Option A. Administer sublingual nitroglycerin and aspirin. Obtain a 12-lead electrocardiogram, ECG, within 10 minutes of arrival, and assess for contraindications to further antiplatelet therapy. Option B. Initiate intravenous fluids and administer a broad-spectrum antibiotic, then proceed with a chest X-ray to rule out pneumonia. Option C. Obtain a detailed social history and inquire about recent travel, then schedule a follow-up appointment with cardiology for a stress test in 2 weeks. Option D. Administer a beta blocker and a calcium channel blocker, then observe the patient in a hallway bed for symptom resolution. The correct answer is A. Administer sublingual nitroglycerin and aspirin, obtain a 12-lead electrocardiogram ECG within 10 minutes of arrival, and assess for contraindications to further antiplatelet therapy. Explanation: this scenario presents a common yet critical challenge in emergency medicine. Rapidly assessing a patient with potential acute coronary syndrome (ACS) and determining the most appropriate initial management. The professional challenge lies in the need for swift, accurate risk stratification to guide immediate interventions, balancing the urgency of potential myocardial infarction with the risks of unnecessary or inappropriate treatments. The physician assistant (PA) must consider the patient's presentation, risk factors, and available diagnostic tools within the established protocols and guidelines for ACS management. The correct approach involves a systematic evaluation that prioritizes immediate life-saving measures and diagnostic workup consistent with current evidence-based guidelines for ACS. This includes obtaining a focused history and physical, performing an electrocardiogram, ECG, promptly, and initiating appropriate medical therapy based on the suspected diagnosis and risk assessment. This aligns with the PA's scope of practice and the regulatory framework governing emergency care, emphasizing patient safety and adherence to established standards of care. The PA's role is to apply clinical judgment within these guidelines to optimize patient outcomes. An incorrect approach would be to delay critical diagnostic steps, such as obtaining an ECG, in favor of less urgent assessments or treatments. This could lead to delayed reperfusion therapy in ST elevation, myocardial infarction (STEMI), or inappropriate management of non-ST elevation ACS, both of which can have severe consequences for myocardial salvage and patient prognosis. Another incorrect approach would be to prematurely discharge a patient with concerning symptoms without adequate risk stratification, potentially missing a life-threatening condition. These actions would represent a failure to adhere to professional standards of care and could violate regulatory requirements for timely and appropriate medical assessment and management. The professional decision-making process in such situation should involve a rapid but thorough assessment, utilizing a structured approach to risk stratification. This includes considering the patient's chief complaint, associated symptoms, cardiac risk factors, and vital signs. Promptly obtaining an ECG is paramount. Based on the ECG findings and clinical presentation, the PA should then initiate guideline-directed medical therapy and further diagnostic testing as indicated, always in consultation with or under the supervision of a physician as per state regulations and practice agreements. Question 20. Quality control measures reveal a pattern of incomplete documentation regarding the management of patients diagnosed with sexually transmitted infections, STI, in a busy urban clinic. A physician assistant (PA) has recently seen a patient presenting with symptoms consistent with gonorrhea. The PA has initiated appropriate antibiotic treatment and provided the patient with educational materials. However, the electronic health record lacks a clear indication of whether the PA has consulted the clinic's protocol for mandated STI reporting or confirmed the specific reporting requirements for gonorrhea in their state. Which of the following actions represents the most appropriate and legally compliant approach for the PA in this situation, considering the need for both patient care and public health reporting? Option A. Reporting all diagnosed STIs to the health department, regardless of whether they are specifically mandated for reporting by state law, to err on the side of caution and maximize public health surveillance. Option B. Confirming the specific state's reporting requirements for gonorrhea, and if mandated, submitting the required report to the local health department within the legally stipulated timeframe, while also ensuring the patient understands the importance of partner notification and follow-up. Option C. Deciding not to report the gonorrhea case, reasoning that the patient is a consenting adult and reporting could violate their privacy, and that the risk of further transmission is low given the treatment initiated. Option D, assuming that all STIs are automatically reported by the clinic's electronic health record system without individual PA verification, and focusing solely on patient treatment and follow-up appointments. The correct answer is B, confirming the specific state's reporting requirements for gonorrhea, and, if mandated, submitting the required report to the local health department within the legally stipulated timeframe, while also ensuring the patient understands the importance of partner notification and follow-up. Explanation: this scenario presents a common challenge in primary care settings, managing patients with suspected or confirmed sexually transmitted infections, STI, while balancing public health responsibilities with patient privacy. The physician assistant PA must navigate the legal and ethical obligations related to reporting infectious diseases, ensuring appropriate patient care, and maintaining patient confidentiality. The professional challenge lies in accurately identifying the appropriate reporting requirements for STIs, which can vary based on state law and the specific infection, while also providing timely and effective treatment and counseling to the patient. The correct approach prioritizes adherence to the Physician Assistant National Recertifying Examination, PA-NREM, scope of practice, and relevant U.S. federal and state public health laws. Specifically, it involves identifying STIs that are mandated for reporting to public health authorities. This ensures that public health agencies can conduct contact tracing and implement measures to prevent further transmission, thereby protecting the broader community. This aligns with the PA's ethical duty to promote public health and comply with legal reporting requirements. An incorrect approach would be to fail to report a mandated STI. This constitutes a violation of public health regulations, potentially leading to penalties for the PA and the healthcare facility. It also undermines public health efforts to control the spread of infectious diseases. Another incorrect approach would be to over-report conditions not mandated for reporting, which could lead to unnecessary administrative burden and potential breaches of patient confidentiality without a clear public health benefit. Furthermore, providing treatment without adequate counseling on transmission, prevention, and partner notification would be a failure in comprehensive patient care and public health responsibility. The professional decision-making process in such situations should involve 1. Identifying the specific infectious agent and its associated reporting requirements according to current U.S. federal and state public health guidelines. 2. Assessing the patient's clinical presentation and diagnostic findings to confirm the diagnosis. 3. Implementing appropriate treatment and management strategies. 4. Ensuring all mandatory reporting obligations are met promptly and accurately. 5. Providing thorough patient education regarding the diagnosis, treatment, prevention of future infections, and the importance of partner notification.